My name is Angela Kribs. I'm head of the Department for Neonatology at the University Hospital at Cologne. And I want to talk to you about minimally invasive surfactant administration. First, I will talk about the question why surfactant administration is important. We have the dilemma that the outcome of extremely low birth weight infants treated with nasal or pharyngeal CPAP alone as primary respiratory support is at least as efficacious as intubation, surfactant application, and mechanical ventilation. But we know since long time that nothing has improved the outcome of the very tiny babies more than the application of surfactant. And so we have the dilemma that CPAP alone is related to withholding of surfactant, but surfactant should be given because it is important for the immature lung. So the hypothesis is that surfactant without any mechanical ventilation, but with CPAP-supported spontaneous breathing, could be the combination of two highly effective principles. And nowadays, surfactant application via a thin catheter during spontaneous breathing with CPAP is a way to give surfactant without any mechanical ventilation. There are a lot of observational trials and also until now 5 prospective randomized controlled trials evaluating the surfactant application via a thin catheter. And the findings of the observational trials and the randomized trials are quite similar. All trials demonstrate a decrease of FiO2 and distending pressure after the procedure. There is less need for intubation during the first 72 hours compared to historical controls, and in the randomized trials also to the control groups receiving surfactant via intubation during mechanical ventilation. And there is also a trend to shorter duration of different kinds of respiratory support, such as CPAP, mechanical ventilation, or supplementary oxygen. For infants with a gestational age below 26 weeks, we observe also lower mortality, less severe IVH, and less air leak. However, we have also discussed about side effects. And the consistent findings in observational and prospective randomized trials concerning the side effects are that there is a need for more than one attempt to be successful with the application in 10 to 25% of the infants. That is very dependent of the experience of the operator. There is sometimes a need for positive pressure ventilation via mask after the procedure. Although this side effect is related to the experience of the person who performs the procedure. Bradycardias and desaturations of more than 10 seconds are observed in 10 to 35%, but they can be managed well with positive pressure ventilation via mask after the procedure. Dislocation of the catheter and thereby mal-application of surfactant and surfactant reflux from the trachea are observed rarely but may occur. We can summarize that the increasing use of CPAP as initial respiratory therapy of preterm infants with RDS raises the question whether surfactant application during CPAP is possible. And there is certainly an urgent need for methods to administer surfactant without any mechanical ventilation. A number of observational studies demonstrate the feasibility of surfactant application during CPAP via a thin endotracheal catheter and led to the hypothesis that the method may be beneficial. First randomized controlled trials demonstrate an effect on the need of mechanical ventilation, and reduction of neonatal complications was also observed. This was especially the case in extremely preterm infants. Certainly, there is a need for further large randomized controlled trials, but they are certainly justified according to the promising results of the first trials. Thank you for your attention.